answering your
We're recording now, so go ahead whenever you're ready.
Okay. Okay, good morning, everybody. My name is Amneet. I'm one of the geriatric PGY5s at University of Toronto. Today, I'll be presenting the short presentation on association between purpose in life and objective measures of physical function in older adults. This article was published in JAMA Psychiatry in July. So I have no conflicts of interest to disclose of. And so I'm going to just start by jumping into it and speaking of the background of sense of purpose. And so why is sense of purpose important? Recently, there's an increased focus on resilience in aging research. There's an effort to identify protective factors that allow a person to maintain their health. And one such factor that is now being researched is having a higher sense of purpose. A higher sense of purpose is described as the extent to which people see their lives as having meaning and a sense of direction and goals. It is often described by having the sense of usefulness to others, greater life engagement, or described as having life that is worth living. Purpose is thought to be especially important because it's shaped by one's social structure and life circumstances, and therefore believed to be a modifiable risk. Previous studies have showed us that higher sense of purpose was associated with greater likelihood of engaging in healthy behavior. In this particular study, each unit increase in purpose was associated with higher likelihood that people would obtain a cholesterol test or a colonoscopy. Males in this study were more likely to receive a prostate examination, and females were more likely to receive a mammogram. And each unit increase in purpose in this study also was associated with 17% fewer nights in hospital. Other studies have shown that greater baseline purpose in life was associated with reduced likelihood of stroke during a 4-year follow-up, and that greater baseline purpose in life was associated with lower odds of having an MI in a 2-year follow-up. In terms of cognition, purpose in life modified the association between global measure of Alzheimer's disease pathological changes in cognition, such that participants who reported higher levels of purpose in life exhibited better cognitive function despite the burden of Alzheimer's disease. In a meta-analysis with 10 prospective studies and a total of over 136,000 participants included in the analysis, there was a significant association with observed between having higher purpose in life and reduced all-cause mortality and cardiovascular events. So as we can see, purpose has been studied to be associated with engaging in healthy behavior, reduced likelihood of some diseases, and reducing all-cause mortality. However, there have been no studies as of yet to look at the association with purpose in life and functional measures. An association with functional measures would be important, as we know both gait speed and hand grip have been associated with major health endpoints, including morbidity and mortality. Gait speed has been associated with survival in older adults, while a meta-analysis previously showing that hand grip strength has a predicted validity for decline in cognition, mobility, functional status, and mortality in older community dwelling populations. And for that reason, this particular study came together. So essentially, the study wants to take previous associations that purpose contributes to one ability to maintain independent physical function and see if there's an association with objective performance measures. This study therefore asks if higher purpose was associated with decreased risk of developing weak grip and slow walking. The design of the study was a longitudinal cohort study, and the population included participants from the United States Health and Retirement Study, which is an ongoing nationally represented panel of older than 50 adults. 50% of this population was then selected for an enhanced face-to-face interview with physical function assessments. The measures included purpose, which was measured at baseline using previously validated 7-item purpose in life, along with physical function measures, including grip strength and walking speed, which were measured in 2006 and again in 2010. The outcome that the study was looking for was risk of developing weak grip or slow walking speed. The participants for the study were derived from this 50% of the health and retirement study that was selected for face-to-face interviewing and functional measures. Participants were left to psychological survey and from the initial 8,706 in the group that were left to survey, about 7,700 completed the survey, and these were the participants that were screened for the two groups. On the left, the sample for grip strength was selected from all patients over 50, so almost the entire cohort, and exclusions included patients that were ineligible because they resided in a nursing home, had a proxy complete the survey for them, or had a telephone visit rather than a face-to-face visit. Additionally, participants who did not consent and who had safety concerns, especially in regards to swelling, recent surgery, or if the interviewer did not think that the test was safe for them, these people were also excluded, along with anyone that had a baseline weak grip strength at the beginning. They were also removed. And so that number resulted in 4,486. On the walking speed on the right side of this chart, you can see that out of the 7,700, we were left with 1,400. And once again, all patients that were ineligible for the same reasons were taken out. Here we have a much smaller number because only patients older than 65 were taken. Also, anyone that had slow walking speed at baseline was ineligible. So looking at table 1 and at the grip strength column, we see that the mean age of patients was about 63 with a standard deviation of 8.2. They were 59% female, 75% white, and more or less equal among different total wealth brackets. Their number of illness was on the lower end in comparison to our patients at just 1.6. Looking at the walking speed cohort, the mean age here was a little bit older at 70.8 with a standard deviation of 6.5. A larger proportion of these participants were white, making for a less ethnically diverse group, and 33.9% of them were in the highest total wealth bracket, which is almost greater than 600,000. This group's number of illnesses was a mean of 1.9. And interestingly, when looking at exercise frequency for both groups, hand grip and walking speed, they had a 63 and 69% respectively reporting exercise greater than once a week. So they may be a little bit more physically active than some of the patients we see. Covariates were assessed by self-report in 2006, and they include socio-demographic characteristics, including age, sex, marital status, education, and total wealth. Baseline health was assessed by summing the number of major chronic illnesses, including heart problems, stroke, cancer, high blood pressure, diabetes, lung disease, or arthritis. Depressive symptoms were assessed using a validated 8-item depression scale, and health behaviors included smoking status, frequency of exercise, and frequency of alcohol consumption. For the analysis of the results, there were 5 models that were replaced. The model 1 was the unadjusted data. Model 2 was minimally adjusted for age, sex, and race. Model 3, which was referred to as the core model, was adjusted in addition to the previous factors, socio-demographics of marital status, education level, and total wealth. Model 4 also had baseline health and depressive symptoms added, and Model 5 was adding the health behaviors. Looking at the results between the association between one standard deviation increase in baseline purpose in life and the risk of developing weak grip 4 years later, we see that there was an inverse association between higher purpose and a lower risk of developing weak grip strength. In the core model, one standard deviation increase in purpose was associated with 13% decreased risk of developing weak grip strength. However, after further controlling for all covariates, results did not reach conventional levels of significance. So the demographic column would be the core model that's squared there. Now, looking at the association between purpose and 4-year change in grip strength, it was consistently positive in all of the models, with higher purpose associated with more grip strength improvements. Now, after adjusting for socio-demographic characteristics, each one standard deviation increase in purpose was associated with a modest increase in grip strength with a coefficient of 0.27. Moving on to the results for walking speed, looking at the results between the association between 1 standard deviation increase in baseline purpose in life and risk of developing slow walking speed 4 years later, we see that there was a strong inverse association between higher purpose in life and lower risk of developing slow walking speed across all models. In the core model, which is the demographics model here, each 1 standard deviation increase in purpose was associated with 14% decreased risk of developing slow walking speed. Even after controlling for baseline health, depressive symptoms of health behaviors, there was 11% decreased risk of developing slow walking speed with 1 standard deviation increase in purpose. And finally, looking at the association between purpose and 4-year change in walking speed, we can see that 1 standard deviation increase in purpose was associated with a modest increase in change in walking speed. After adjusting for additional covariates, it remained positive, but did not reach significance. So looking at the critical appraisal of cohort studies, one appraisal tool is the Newcastle-Ottawa scale for cohorts. It's divided into appraisal into selection, comparability, and outcome. And looking at selection, we see that the exposed cohort was representative of the average 50-plus US population, with data being used from this nationally representative panel study of older adults. The selection of the non-exposed cohort was from the same group. Ascertainment of exposure was through the psychological well-being scale. And number 4, the outcome of the study was looking, number 4 asks if the outcome of interest was present at the start of the study, and because the outcome of the study was looking for a change or reduction in function, they were not able to demonstrate if it was present at the start of the beginning. The study did examine the possibility, though, that better physical function would lead to higher purpose by testing to see if higher function at baseline was associated with increased purpose during follow-up, and no association was evident. Looking at comparability of cohorts, the study controlled for sociodemographic characteristics, baseline health, depressive symptoms, and health behaviors. The outcomes of walking speed and hand grip were measured. The follow-up of 4 years was likely not significant for the hand grip group, as among the 4,400 participants in this group, only 9% developed what was considered a weak grip strength during this time. And compared to the walking speed group, about 47% of them actually, over the 4-year period, ended up having what was considered a slow walking speed. And so this could be secondary to the fact that the hand grip cohort was much younger and would take longer to have this significant decline, or it might just be a factor that takes longer to decline. In regards to the adequacy of follow-up, there was a loss of about 9.1% of grip strength respondents and 13.1% of walking speed respondents. Unfortunately, they didn't comment on what level of purpose these individuals had, so that was some data that would have been helpful. Another tool for appraising cohort studies comes from the Critical Appraisal Skills Program. And looking at aspects of this tool that were not covered in the previous tool, we can see that number 1, the study did address a clearly focused issue. Number 2, the cohort was recruited in an acceptable way. Number 3 and 4, the exposure and outcome were both accurately measured. And then looking at question 5, it asks if the author identified all important confounding factors. And I think this is where the study may have missed the point a little bit. Because the cohort was much younger than the patients we see, especially for the hand grip cohort, a mean age being in the young 70s, being in the young 60s, I think employment becomes more of an issue, and it was not identified as a confounder. Patients with a higher sense of purpose may have it because of their jobs, and their jobs may be also the reason why they're able to maintain an adequate gait speed and hand grip. They also did not ask if patients were living with or had other family members than a spouse. One could infer that a grandmother that is a caregiver to her grandchild may be more likely to have a higher purpose than a patient without family, and then at the same time be able to maintain her function for this reason.
Grandfathers can do that too.
Grandfathers can do that as well too. Moving on to 5B, the study did take into consideration other confounders, and then we've discussed question 6, so we'll move on. And we'll just skip over the slide for time's sake. And then the last section of this tool was looking at if these results will help locally. And I would say that this is more the case for the walking speed cohort than the hand grip cohort due to the mean age of the group. So even though the mean age of 70.8 is still on the younger side, it's more comparable to our patients, but there was other issues with the sample. They were not as ethnically diverse as the population we are used to seeing. They're from a higher wealth bracket, they're less frail, less medical issues, and more active to begin with. Question 11 asks if these results fit with others available. And although there has not been a direct study to look at purpose and functional measures, there have been previous studies looking at purpose and disability, with higher purpose associated with reduced risk of disability over time. There was also another study that found higher purpose was associated with fewer physical functional limitations with ADLs. So it kind of does match what was seen in those studies. And to summarize the limitations for the study, so one thing was unsure what proportion of the missing data was from what group. Were these people with higher purpose, or was it patients that also scored very low on the purpose scale that were then not the ones completing the follow-up surveys? Purpose in life, this article introduces purpose in life as being a variable that can be modified. And I think that's important to consider because in this study, it was only measured at baseline. So I guess we could question, is purpose of life in these individuals, would it have persisted at the same level through the 4-year period? And I think there may be some benefit of testing it throughout the study and maybe once in between as well. We spoke of unmeasured confounders, including employment, family, hobbies. I think responsibilities that are not included in exercise or tasks also make a difference for that. The GRIP population cohort was especially much younger than our patients. Both cohorts were much healthier and less frail than our patients. It's not an RCT, so there's no causal relationship. And the questionnaire and subscale of purpose may not be properly detecting people that have purpose secondary to their responsibilities and may only be picking up the people that have this sense of purpose because of a sense of well-being. And so we can see that multiple cohort studies showing association of purpose in life with positive health outcomes. This study shows that there is an association between purpose in life and decreased risk of developing slow walking speed. And there may be an association with purpose in life and a modest increase in grip strength. And this study was important as it provided an objective measure rather than self-reported outcome that was associated with purpose for the first time. And the bottom line is that this is clinically significant to geriatrics because focusing on methods to evaluate patients' sense of purpose and optimizing this variable may be an important practical component that can be added to geriatric care. And thank you. Any questions?
Thanks very much, Amneet. Should we take questions from the room there at Sinai with you?
I just have a comment. I think they should have said potentially modifiable risk factor. But the other thing is we all know the problem with correlation, but I think we sometimes forget that the risk of finding correlations that have no causal relationship whatsoever increases with age. And the way you think of it is you've got a 20-year-old car with 250,000 kilometers on it. That rusting left fender and the wonky transmission are both bad, but they have no causal relationship. So the older you get, the more correlations you're going to find. And you know, a couple of common ones that were discounted were skin tags and colon cancer, age being the factor between, and coronary artery disease and earlobe creases, which turned out to be a pretty useless finding as well. And so you got to be particularly wary about correlations in an elderly cohort.
Thanks, Barry. Any other questions there from Sinai? Questions or comments? What about down at St. Mike's?
Hi, yes, I have a question. Really interesting presentation and paper. So thank you for taking the time to prepare this. I just had sort of a comment and question together because I was just sort of curious what you think and what everybody else thinks about this too. So I see in table 2, they looked at the risk ratios for the association between 1 standard deviation increase in baseline purpose of life and risk of developing weak grip strength or slow walking speed. And so we see for the grip strength, when you get to the fully adjusted model, you lose the association. For the walking speed, it persists. But then when they looked at the outcome a slightly different way, right? So here then in table 3, they modeled it as a mean change in physical function, but they looked at the same association as such, just they looked at it as continuously reported. And then there was an association in the fully adjusted grip strength model, but not for the walking speed. And so I was like, well, that's interesting, because they looked at the data one way and they found an association with one outcome measure and not the other. And then they reported it a different way and they found the opposite. And so then I'm left kind of sitting here being like, well, was there really any like meaningful association or not? I don't know.
Yeah, so I agree with that. So looking at the results in the two different ways, we do kind of get a two different sense of the results. I'm not sure if that would mean that purpose in life is more of a protective factor in decreasing your walking speed, but does not necessarily help you attain a faster walking speed. The other issue that could be playing a role here is that for the decrease in walking speed, it was kind of the binary yes or no if they reached that number of what was considered a slow walking speed versus the actual change, and I'm not sure how those numbers played out.
Very much. I think we'll move.
Yeah, well, that's exactly sort of getting at the point I was sort of getting at, actually, is that when you look at in table 2 like that, and they said that, right, they modeled the data two different ways and then they found opposite things depending on how they did it. And so that's why I'm kind of like, well, was there really, I'm not sure that we can really draw any strong conclusions because of the sort of not really contradictory results, but certainly results that don't support one another, right? It would have been much more convincing if they would have found, you know, in both ways that they looked at it, you know, grip strength didn't support, and then walking speed, or there was an association then between walking speed in both of the ways they measured it and not for grip strength. You know what I mean? They found opposite. So I don't know. Thank you. That was interesting though.
Thanks very much for raising that point. And apologies, my microphone's not working well. I think we'll transition to Jawid Darvesh's. We'll let you guys do this, please.
Just hold on. Laptop closer.
Are we doing?
Okay.
Oops. All right. Okay, good morning, everybody. I'm Jawid. I'm one of the PGY5s from University of Toronto, and I'm going to be doing the long presentation today. So we'll talk about this paper that came out in November of 2017, and the title is DHA Supplementation Improves Cognitive Function via Enhancing the Amyloid Beta-Mediated Autophagy in Chinese elderly with mild cognitive impairment, and it was a randomized controlled trial. I have no conflicts to disclose. And so our objectives for this part of the talk will be to have an overview of the mild cognitive impairment, also to discuss about the role of DHA in cognitive impairment, and then lastly review the RCT. So what do we know so far about mild cognitive impairment? There was a recent article that was published in 2018, and it had a great summary of all the information about the mild cognitive impairment. So there, as you know, many definitions of mild cognitive impairment. So for the sake of simplicity, I have included one of them, the shortest one, I guess. It's that cognitive deficits with minimal impairment of ADLs and IADLs. as you know, that the mild cognitive impairment prevalence does increase with age, and in our population, in the studies they looked at, the population of 80 to 84 had almost a quarter of people had mild cognitive impairment. So older adults with mild cognitive impairment are at increased risk of progressing to dementia than their age-matched controls, and the range is about 10 to 15%. In folks that have mild cognitive impairment, they progress to dementia, whereas the other age-matched controls have much lower rates of progressing to dementia. So why do we care about the mild cognitive impairment? Because the diagnosis of this they have profound implications for the prognosis of dementia as well as for future planning. A lot of people get concerned when you give them the diagnosis of mild cognitive impairment, and so discussing about treatment options and also about the potential for reversing the mild cognitive impairment is very important to people. Unfortunately, thus far, there is no high-quality evidence to support any pharmacotherapy for mild cognitive impairment. The only recommendations that we have aside from cognitive interventions is an exercise program, 6 months, and it's twice a week. Basically, that has been identified to be helpful in mild cognitive impairment. And of course, the role of a geriatrician to make sure that we reverse all the other potential reversible causes. So what is DHA? It is a essential fatty acid. It's an omega-3 polyunsaturated fatty acid. And there's much debate about whether humans can synthesize it or not, but it's generally understood that you need this in your diet to basically sustain the brain function. And in terms of the Western diet, we know it is lower in DHA. There are studies that have shown that our diet is lower than, let's say, in Eastern countries where the main source of the DHA is mostly in fish and walnuts, flax seeds, and of course now you can go to the supermarket and you'll see that there are products with DHA added to it. For example, eggs, and also we add DHA to infant formulas. And a few weeks ago, when I went to buy an infant formula, the price difference was about $10 more expensive for the formula with DHA added, and of course I bought it. Currently, there are no national recommendations for DHA, but it's a supplement that is often taken, and also there are studies show that as older folks use more supplements, and DHA is one of them that people spend a lot of money buying this. What do we know so far about DHA is we know that the deficiency of DHA is detrimental to neurocognitive development. Mostly it's shown in animal models. There's also some studies that showed about the association between an amyloid burden and also a tau buildup, but mostly in animal studies. There has been a challenge in interpreting these particular results in humans. Also in animals, when they did the studies, they found that it improved their cognition. But of course, we are a much more complex I guess animal than the other animals. So with us, with the cognition, it has been a lot more complicated to make those studies. In terms of the DHA and cognitive impairment, so there has been a lot of cross-sectional prospective cohort studies and a lot of more like correlational studies that have shown that there is a correlation between higher levels of DHA and better cognition or lower incidence of dementia. However, the issue with a lot of these studies is, for once, a lot of them relied on self-reported intake of DHA, and a lot of the time they intake of fish was counted as possible increased source of DHA. There's one study in particular that I found this was interesting, where they took a large cohort of women. This was the WIMS study, the Women's Health Initiative Memory Study, where 6,700 women above the age of 65, they were followed for quite a long period of time, 9.8 years. And what they found out in this study was they took baseline levels of DHA in these women, and those women that had higher levels of DHA at baseline, they had fewer incidents of dementia throughout the study. And of course, whenever we talk about correlational or cohort studies, there's a challenge because we don't know the causality. That's one difficult thing, because we don't know if having, let's say, dementia or cognitive impairment, does that cause you to have lower intake of DHA just by virtue of choosing different types of food, or vice versa? And it's difficult to say that. Also, it's very difficult to control for confounding variables. And also the authors of that previous study mentioned that the women that were consuming or had a higher DHA at baseline, they had a higher education level, higher socioeconomic status. So as you can see, it's very difficult to control those things in cohort and cross-sectional studies. So there was a large study done. This was a good study with thought to have good methodological factors, and this was this was published in JAMA in 2010, and this study basically looked at the supplementation of DHA and cognitive decline in Alzheimer's disease. And so this was a randomized, double-blind, placebo-controlled, multi-site study in the USA, and they had 402 participants with mild to moderate Alzheimer's disease, and their MMSE scores at baseline were 14 to 26. And so they assigned 60% to the DHA group, and it was 2 grams per day, and then the 40% of them received placebo, and the follow-up period was 18 months in this study. And the outcomes that they were interested were ADAS-Cog, the clinical dementia rating, functional status. They were using the ADLs scale. And then also they looked at, in a subset of their group, they looked at brain atrophy as well. And what they found out was that both groups had equal rate of cognitive and functional decline throughout this 18-month period, and that there was no improvement in the intervention group versus, or no slower rate of decline in the intervention group versus the control group. Similarly, also they showed that both groups had similar rates of brain atrophy, and no difference was found. So based on this study, and this study has been quoted in many other articles, including a Cochrane review that I'll talk about shortly, that basically the outcome of this was that DHA is not thought to be beneficial in Alzheimer's disease. The caveat was there was a small, apolipoprotein E negative individuals, and then there was a difference in one primary outcome. There was a difference in the ADAS-Cog, and also a secondary outcome was an MMSE, but then they didn't have a difference in the other outcomes, so the authors thought that this was likely clinically insignificant. So there was a Cochrane review done on DHA and Alzheimer's disease. They looked at mainly the 3 RCTs, one which I discussed, and then 2 other RCTs. They had they had lesser number of patients, and they found that the overall quality of evidence coming out of these studies was high, and they found that there was no convincing evidence for the efficacy of DHA or omega-3 PUFAs supplements for the treatment of mild to moderate Alzheimer's disease. But the Cochrane review also mentioned that they also they thought that the adverse effects are likely low, but they could not make a final statement in terms of the tolerability of DHA. But it's interesting that if you look at the JAMA 2010 article, the folks that were getting DHA, that group, they had more adverse events in almost all categories than their counterparts, but they thought that the difference was not statistically significant. There was an article that was published about a year before this one, and it was actually essentially the same same study patients and same population, but in that article, these same authors, they commented on hippocampal volume and MCI, and then this was like a one-year follow-up period. Whereas the study that we're discussing today is a 2-year follow-up, and they haven't mentioned about the hippocampal volume. And what's interesting to note in this particular study that was published in Journal of Alzheimer's Disease, again in 2017, was that this was, as we will discuss today, an RCT double-blind placebo-controlled. It is in Tianjin, China, and they had 240 participants, the same participants for our study, and 65 and older, and 120 received DHA, 120 received placebo, and they followed them for 12 months. And the bottom line from that was they did MRIs of the brains of these individuals with particular focus on the hippocampi, but they also looked at cerebral volume and also ventricular size and all that. And what's interesting in this study was that in both groups, in the intervention group, the brain volumes actually increased. Especially like as you can see here, I have a snippet right here. The total hippocampi volume actually increased in the intervention group, whereas in the control group, it actually remained pretty stable. So this was different than, of course, the other study that showed that both groups had a sort of equal rate of atrophy. So what is the sort of question of this study or the objective of this study? So the authors had a few, of course, hypotheses, and then they also wanted to study the effects of DHA on cognition. So the authors mentioned that DHA is critical for brain function, but the mechanism of action is not clear. That the amyloid plaques, as we know, is thought to play a role in Alzheimer's disease, and particularly it's the amyloid beta 2 that's particularly toxic to the brain, and it is thought that the clearance is impaired in Alzheimer's disease. So the authors wanted to study whether at 24 months of DHA supplementation would improve cognition via enhancing the autophagy, or essentially clearance of the amyloid beta proteins in Chinese elderly with mild cognitive impairment. So they're not looking at dementia. They're looking at only mild cognitive impairment in this study. So the authors, they basically took 240 community dwelling adults. They were above the age of 65 or older, and they had diagnosis of MCI, and they used the Peterson's criteria. Essentially, they used, I guess, the diagnosis of MCI. There are some variances, but more or less, they looking at all the criteria that they looked at, they were able to articulate what how they came up with the diagnosis of dementia. Essentially, people that would otherwise basically had some cognitive deficits but did not meet the criteria for dementia, and also their function was not affected. And the intervention group received an algal derived, so it's basically from algae. It's a DHA, which was provided by Martech Biosciences from Columbia, Maryland. And these were in capsules, 2 grams per day. And then the control group got corn oil capsules. And they made sure that both the, so these were both provided by the same pharmaceutical company, and they were flavored orange, and also their colors were the same. So the thought was that both the color and the flavor would conceal the fishy aftertaste that you have from the DHA, and the hope is that the study participants would not know whether they're taking corn oil or the DHA. The outcomes in this particular study that they were interested was they used the Welsh the WACE RC, it's the modified cognitive test. We'll discuss about this in a bit. And also they used the intelligence quotient. So they didn't use the other typical things that are in a lot of our studies, like the ADAS-Cog and the clinical dementia rating, but they used a different type of cognitive function testing, and this was the main outcome. And they also, as secondary outcomes, looked at the serum DHA levels throughout the study, and also the amyloid beta related biomarkers, and also the markers of autophagy in this study. One thing that was interesting was that they did not look at the rate of conversion to dementia as an outcome. And then the setting was in Tianjin, China, and this was in one single site in the Tianjin Medical University Center between 2013 and 2015. So the inclusion and the exclusion criteria weren't really clear cut in this study. I had to sort of read in between the lines and divide between inclusions and exclusions. What they made a general comment about who they included in the study, but I think as part of that, they also mentioned who they were not taking the study. So from what I gathered from this study was that they, of course, the inclusion criteria were you had to be age 65 and older, and you had to meet the diagnostic criteria for MCI, and you had to be in general good health. This was basically, they didn't further elaborate on what they meant by general good health. Their exclusions were that if you were non-ambulatory, they didn't take in the study. Also, if you had to have sufficient hearing and vision for compliance with their testing and procedures, they should not have terminal illness. Also, mental disorders. A few examples they gave were like major depression, schizophrenia, bipolar. They should not have had any use of any nutritional supplements that were known to interfere with metabolism or cognitive function in the 3 months prior to recruitment, but didn't specify what exactly the supplements were. And then also, like, they didn't include anyone that were living in a nursing home or also were on a wait list to go to a nursing home. In terms of the recruitment and the randomization process, so they used the random cluster sampling of 6 geographical convenient communities in the Nankai district, and they say that these specific districts that they looked at, they had a higher proportion of older adults living in them, they basically used, they thought that by randomly selecting these districts that they would have they'd be more representative of the population. And so they interviewed they screened about 4,333 people, out of which the 2,800 agreed to participate, but ultimately only 2,555 were eligible to undergo the physical and psychological testing for this study. In terms of the randomization process, so before starting the study, the 240 participants were divided into 2 groups, 120 for the intervention arm and then 120 for the control arm. And there was a computerized generated random sequencing that was overseen by the study sponsor. Didn't mention which specific study sponsor did that, but that apparently was they were not directly involved in the study design in the study design. So this, I hope you can see this clearly on your screens. So basically, the out of the 2,555 that were eligible, they all basically underwent both physical and psychological testing, and they were tested by trained psychologists who determined the diagnosis of MCI, and only those folks that had MCI from those 2,500 people were included in the study, and there were a number of 248 people had MCI in that population. From those, there are about 8 of them that did not, I guess they left the study and did not wish to continue further, and so 240 patients went to both arms, as we discussed, the corn oil and the DHA. And you can also see that the follow-up rate is quite good here, and that only about 11 dropped from the intervention group, and then 12 dropped from the placebo group, and the reasons were discussed here. One thing I want to point your attention to here on the slide is that in the control group, in the placebo group, they have 7 illnesses and 1 death, whereas on the intervention arm, there are no illnesses that were reported. And a lot of it was either they refused to undergo the cognitive testing or discontinued their medications, or there's also like a section of 2 patients for miscellaneous reasons they were lost to follow-up. But you can see that about 90% of the both groups, they continued with the study, and they used the intention to treat analysis for the moving forward. In terms of the cognitive testing, so this was the Wechsler's, I can't say this right, this is the Wechsler Adult Intelligence Scale. So this was initially designed, this was in Europe, I forgot the name of the researcher that did this, and then they have a modified version of that, revised version in 2008, and they validated it in the Chinese population. I can't show you a copy of this, it's well, for one thing, I couldn't actually find the exact PDF of it, but also that this was in Mandarin and in Chinese language. So in terms of what this test is basically it has 11 subsets. So things that are included as part of this test is the information. There is a section on similarities, vocabulary, comprehension, arithmetic. Also, they're using digit symbol coding, object assembly, and so they have different sections. They also use the neuropsychological assessments. They were done by trained physicians, and so they interestingly used intelligence quotient, and they used the Chinese norms for that age group to report the index. And the three things that they used were the full scale IQ, the verbal IQ, and also performance IQ. So who are our study populations? So looking at this table 1, you can see that they're mostly, the average age is 73. There's about 65% females in both groups. And also, what's interesting on this table, 2 things. For one, both groups look very similar, actually, if you look at the placebo and the DHA arm. Also, what's interesting is that their baseline DHA intake is about 286 micromoles per liter, and the average DHA intake in Canada is 89 umoles per liter. So they at baseline have much higher DHA consumption than we do here. The other thing is that the average blood pressure was 146 systolic, but they only said that the hypertension was in 9.7% of the population. So that was interesting to look at that. In terms of the results, as discussed previously, the different subdomains of cognition that were done through the Wechsler's test and also the IQ, is they found that there was a statistically significant improvement in the full scale IQ, verbal IQ, and also information and digit span. What's interesting to note looking at this table is that both groups had, or the control group, if you look at that, there is no decline in that control group, and it's pretty steady. Actually, then in this top portion, you can see that the control group had almost identical scores throughout the whole study period, which is 24 months. But then there were improvements that were in the intervention group. And then in the other aspects of the test, the p-values were not statistically significant in those ones. The other secondary outcomes that they looked at, particularly of interest, the amyloid beta 42, there was a statistically significant reduction in the level of amyloid beta in the intervention group, whereas in the control group, it essentially stayed the same throughout the study. So the thought was that that was affected by the DHA. And also, so this slide right here, there are different, like all these molecules, so the Biclin, LC3 and all that. So these are thought to be markers of autophagy of amyloid beta. So when you break down the amyloid beta, you produce these ones. And by producing more of these ones, it's thought that you're reducing the amyloid beta. So in this study, they looked at, for example, the statistically significant ones were Biclin, LC3, and LC3 mRNA. And what you find is that in the intervention group, they had higher levels of these, meaning that the amyloid beta was cleared more, or there was more autophagy done in those intervention groups. One thing of interest was that the rate of conversion to dementia was similar in both groups. So they were around 10%, or to be exact, 9.7% in both groups. And then this was just mentioned in the discussion section and not really in the results section. In terms of their adverse events, these were not reported. Also, there is no supplementary material provided for this study, but in looking at breaking down that flow sheet table, I noticed that as we alluded to previously, there were equal number of loss to follow-up. And what's interesting is that the illnesses, there were 7 illnesses in the DHA group, and sorry, this is the placebo group and none in the DHA group. I might have actually these numbers backwards. This the first table might be DHA and the second one is placebo. So now about critical appraisal of this article. So I used the EBM therapy worksheet, and on first look, as you can see, there's lots of greens on this sheet. So yes, this was a randomized study, placebo-controlled. They did concealment of allocation, as well as the blinding was double. And both groups were balanced in the beginning of the study, and also they were treated equally. And the analysis was intention to treat, and the follow-up was actually very good. It was about 90% follow-up. The source of funding was the Chinese Nutrition Society and the DSM Research Fund. In terms of the funding source, I'm not sure really how much that has to do with the supplement sort of industry. But they did have, what's interesting is they did have, they registered their initial protocol with the trial registration, and there were lots of changes made from the initial protocol. And looking at the initial protocol, they initially had 60 patients in each arm, whereas we have 120 patients now. Their follow-up initially was proposed to be 6 months. It was initially designed to be single-blinded, only blinding the patients and not the study researchers. And then the age cutoffs and the inclusion and exclusion criteria were different, but it looks like they have made a lot of changes since their initial protocol. Also, the study and drug placebos were provided by Martic, but there was no mention of whether they paid for these drugs or how they basically got the placebo and the drug. I found some additional strengths in the study. Well, the study design being a randomized controlled trial, double-blind, placebo-controlled. Also, that both groups were similar at the beginning of the study, meaning that they had a good. The randomization worked really well. Also, that they tried to conceal the flavor and the taste of the capsules between the DHA and the placebo. There was low loss to follow-up. Also, this was a longer follow-up time than the prior study in JAMA. This was 24 months versus the other study was 18 months. And then they did an attempt at using the biomarkers for the study, which I thought was really interesting. In terms of limitations, I think that there are many limitations to this study. For one thing, it's a single site as opposed to being different sites across the country. Second, the generalizability of the study to, let's say, especially to the other population, they're mostly native Chinese speaking, higher proportion of women, and they were just from the 6 neighborhoods in Tianjin, China. So whether these results are generalizable to other population, that is a limitation. Also, their baseline DHA intake was high, and the authors did mention that they were near the Bohai Sea, which abounds with lots of quality seafood. So at baseline, they seem to have a lot more DHA consumption than sort of the Western countries. And also, we don't know what the optimal dosing of the DHA is. They chose 2 grams based on the fact that if you go more than 2 grams, the plasma levels do not necessarily increase, but we don't actually know how much DHA is optimal for cognitive health or cognitive improvement. Also, the serum DHA may not really correlate well with the intracellular DHA. So what's inside the brain, it's difficult to correlate whether a higher serum DHA would mean there's more DHA inside the brain. And also, in many other studies, they said that the animal DHA is perhaps a little bit better than the DHA derived from the algae. So they use the one from the algae. And also, the length of follow-up may actually not be long enough in MCI. And as you know, the MCI is not similar to dementia, and so in this population, a lot of them improve, a lot of them stay the same, and also there's a subsegment of them that progress to dementia. So is 2 years long enough? But I think they plan on also following these patients for the next 5 or 6 years. So it'll be interesting to see their next study down the road. In terms of further limitations, again, the use of the intelligence quotient and the Wechsler's test, it makes it difficult to compare sort of those results to what we typically or use as standards for cognition, such as the ADAS-Cog and the also the clinical dementia rating scales. So it's difficult to sort of compare oranges to apples. And also the control groups in this study remained largely unchanged. Typically, we would see some degree of cognitive decline, I guess, if a subsegment of them progressed to dementia, but it just makes the results a little difficult to believe in that the control group remained unchanged and then you had improvements in the intervention arm. Also, the change in their functional status was not measured. That's another limitation. And then also, they did not provide any supplementary information. In terms of additional questions, so again, the main questions that looking at this study that we can ask is, are the differences really in these cognitive scores clinically significant? I know they're statistically significant, but clinically, are they meaningful? The other thing is the use of biomarkers itself is controversial, and stating that the amyloid beta went down, does that really mean anything clinically for us? To show those biomarkers. As we know, the biomarkers themselves they have a lot of controversy attached to them. And also the rate of conversion to dementia was not accounted as an important outcome. I think it's very important to to look at that as a main outcome. And also the rate of progression to Alzheimer's in both groups were the same. So that to me tells me that really the DHA clinically didn't have much meaningful effect. It did not prevent people from progressing to dementia. And again, do we believe the effectiveness of this in the mild cognitive impairment? So in terms of conclusion, I think these results are not consistent with the prior studies. It is difficult to interpret the clinical benefit of the DHA. And also, ultimately, we need more clear evidence before we can recommend for or against the use of DHA in mild cognitive impairment. Those are the conclusions. And these are my references. I would like to thank Eric Wong for his great support and lots of help that he provided me in the study, and also Dr. Shabir Alibai for his help. And with that, I open the floor to any questions you may have.
Thank you so much, Jawid. People can hear me a little bit better now. We'll take any questions for Jawid. Shall we start there at Sinai again?
Okay, it seems
No questions.
no questions
Okay,
here.
down to St. Mike's.
No, large audience, no questions.
Thank you so much. Sunnybrook?
I don't think we have any questions here at the moment.
Okay, thank you. Baycrest?
I don't think we have any questions either.
Okay, so Jawid, I have a question for you. Are you going to try to change your diet or buy supplements? What's the bottom line in terms of the impact for you?
Yeah, so that's a great question. Thank you. So actually, I'm gonna just put this slide up there. So, so the bottom line is the evidence is inconclusive. At least based on these studies, at least this study shows some improvement. It's hard to believe, the atrophy, the hypertrophy of the brain, and also the fact that cognitions kind of improve over time. But also looking at, the adverse effects of DHA, there are some side effects more or less like, I think the ones that I probably think are potentially problematic for our old elderly folks is the blood thinning effects of it. And, a lot of our folks are on anticoagulation and antiplatelets. So, for myself, I think would I supplement myself, with DHA? If I have the money, why not? Whether would I recommend this for my patients? Probably not at this point. It is a low-risk supplement. It could or could not offer any benefits to them, but if they really have the money and they were willing to spend on DHA and they, let's say, don't have any other concerning, like, bleeding or poor sort of bleeding status, I could say, sure, we can give it a try, but just the evidence really doesn't exist to back up an improvement in cognition. But that being said, there's also lots of other things about DHA and psychiatric health and DHA and many other sort of cardiovascular and those other health. So if they're taking DHA and they're adamant, I think, they can take it.
question. Can you go back to that previous slide? You commented some of the supportive evidence for DHA was the suggestion that in areas with greater DHA consumption, there are lower rates of, and I couldn't remember, was it dementia, was it MCI, was that like there's one of your introductory slides, I don't know if you had looked at those original slides, like how big a difference was that when you looked, even on these regional levels? Just
this one right here,
this one, yes.
Okay, so this is actually, I didn't go through every single study. I read the abstracts of most of the most of the studies. The thing is that they lots of these studies were, for one thing, self-reported. They handed out questionnaires and people recorded their fish intake, or some recorded whether they took supplements or not, and then they looked at that and basically looked at cross-sectional, how many had dementia, how many had there wasn't specifically MCI, but they how many people had dementia. They also did other studies. So that, yes, about the effect size, there was some statistically significant effect sizes, but really nothing that I found at a magnitude that was so high that you'd say, yeah, there was a big difference. Again, the couple of studies that did show that the magnitude was a bit higher, but they also mentioned that they had a lot of other confounding differences, that these people, for example, had a higher education level, they were wealthier, so could the differences be because of those things versus, their DHA consumption? Again, the problem with, the studies that were done, in terms of looking at cross sections and also the cohort or sort of self-reported studies is that, they just, it was almost impossible to control for all the confounding variables. So it is thought that DHA is helpful with cognition. It is thought that it's helpful with lower incidence of dementia. But unfortunately, when they did in a randomized control setting, it just hasn't really, except for this study which showed some statistical significance, the other studies have not shown. Even meta-analysis of the results of the RCTs did not show a statistically significant, let alone clinically significant differences.
Okay, thank you very much to both presenters. This draws us to the close of Journal Club for this month. So thank you very much to Jawid and to Amneet. And join us next month. And please sign up, subscribe to the YouTube channel. We'll include the link in the evaluations and with the notices going forward for Journal Club. Thanks very much, everyone. Have a good day.
Thank you.
Thank you.